Coming up in this episode of Voices of Care, I'm speaking with Toby Lewis, the Chief Executive Officer of Rotherham, Doncaster and South Humber NHS Foundation Trust. We'll be discussing, amongst other things, the NHS long-term workforce plan and how we can truly turn the dial on health inequalities.
The reality is we need to treat poverty as an insidious condition that drives ill health. And for me, what that means is the NHS has to get serious about housing and get serious about jobs. 40 to 50% of the health outcome, health status that our people experience is grounded in those two factors. The NHS is the rich part of public services. It's the part that hasn't lost 40 to 50% of its funding over the austerity period. So we really do need to come to that table recognising that position. In my own family life, people receiving domiciliary care from people paid less than the real living wage, who are then paying for a taxi to go between appointments at 10 o'clock at night. We wonder why we can't retain people into those roles.
Hello, I'm Suhail. Welcome to this episode in the second series of Voices of Care podcast. I'm joined today by Toby Lewis, the Chief Executive Officer of Rotherham, Doncaster and South Humber NHS Foundation Trust. The Voices of Care podcast looks to get to the heart of the issues facing the health and social care sector and how we can enable the healthcare workforce of the future. This is extraordinarily timely given the publication of the NHS long-term workforce plan that seeks to turn the dial across all occupation groups. And in that regard, it's really important to hear from someone who's spent their career across all segments of the healthcare service here with the NHS, and therefore I'm delighted and welcome Toby.
Good to be here.
It's great to have you here. And before we go and deep dive into the workforce plan and the wider healthcare challenges that the system faces and opportunities, perhaps it'd be good to give you a bit of a broad background in terms of the work that you're doing. It's been a few months now since you joined RDASH as CEO.
That's right, we're counting it in months now. I'm past the 100 days in North Lincolnshire and South Yorkshire, where we're providing care for people with learning disabilities, running mental health services. We've got the full range of adult and children's community health services. A really remarkable set of teams across a large geography, looking after about 750,000 people in a very deprived part of the country. Very rewarding work.
Fabulous. And the provision has also evolved from focus simply on mental health and learning disabilities to wider community services.
Absolutely, and we need to continue, don't we, to break down those boundaries. For people who are perhaps frail, for children and families, some of those boundaries are the silos that the English NHS tends to create. So absolutely what RDASH is about is beginning to try and break down some of those barriers.
Looking at the bigger picture, the NHS is of course perennially in the news. We've got industrial action in the backdrop throughout the year, massive shortages, 112,000 according to the NHS workforce plan. You've spent 25 years, hate to remind you, in your career across mental health, primary care, hospital settings, the odd medical school founded along your responsibilities. In terms of the depth and breadth of this current crisis, how does it compare and how is it impacting the workforce at RDASH? Well,
it's important we don't normalise that. I mean, even a sense of perennial difficulty creates a sense that what we're facing now is always with us. I'm realistically optimistic about the future. But of course, there are profound vacancies. Many people on the back of the pandemic are choosing to leave the workforce. So that makes a big difference, doesn't it? If you're working in a team and actually you don't know some of the people you're working with, then lots of other things that we take for granted in terms of improving healthcare, learning, teamwork, those things dissipate because I'm trying to work out who I'm working alongside. And if you take RDASH specifically, probably our strongest pressure point is in terms of consultant psychiatrists in subspecialist areas where we've got 23 folk in as locums, and we're probably spending £5 million a year trying to make that work. I think it's the third highest percentage in the country, and obviously we've got a commitment to change that over time. But to do that, we've really got to make working in these environments rewarding for people, because we're in an international market now, aren't we? So we need to find new and more thoughtful ways of making working in our health service something that people really want to stay and do.
Absolutely. Now, the bigger picture, I want to just step back a bit. The workforce challenges, the shortages are all part of a much wider picture. And your work as a senior visiting fellow at King's Fund focused a lot on healthcare inclusion. Now, it's almost 200 years since Disraeli wrote Sybil, The Two Nations, where he bemoaned the challenges and the differences that were available across our nation. We're looking at some of the stats now. The most deprived groups, life expectancy, just as one indicator, shows a huge disparity. And it's been 15 years or 13 years since Marmot. Just to get your expertise on that bigger picture, because if we're going to have a hope of changing the outcomes and managing demand, because that's the driver of the shortages in terms of workforce, what are the things that we need to do? Because we have a lot to do in that regard.
We certainly do. I mean, let's start by naming it. So this is a conversation about poverty. Poverty is bad for your health, and we can think about that in all sorts of philosophical ways, but the reality is we need to treat poverty as an insidious condition that drives ill health. And in that sense, the NHS needs to face up to that reality. We probably need to do perhaps two or three things. There's a disproportionate emphasis needed to what Michael Marmot called proportionate universalism, isn't there? So we need to lean into communities that traditionally we have excluded ourselves from. Of course, we need to focus on healthcare inequalities, but if we just focus on healthcare inequalities, in other words, differences of access and so on, we really will not make a dent in differences of outcome, huge disparities of outcome, particularly something like healthy life expectancy. You're talking about 20 or 25 years of productive family life, economic contribution that somebody won't be able to make if they're at the extreme end of that deprivation. And for me, what that means is the NHS has to get serious about housing and get serious about jobs. 40 to 50% of the health outcome or health status that our people experience is grounded in those two factors. So we can't be a bystander to that conversation. Remember, the NHS is the rich part of public services. It's the part that hasn't lost 40 to 50% of its funding over the austerity period. So we really do need to come to that table recognising that position and focus hard on housing and on jobs, in my view.
Absolutely. Now, you wrote very eloquently and passionately about this when you wrote about it with the King's Fund, and I just want to briefly touch upon the role, the promise potentially that the integrated care systems offer, because we've had this seminal moment of the statutory footing of them now, a year into it. Are you seeing hope in terms of tackling it in an integrated way? Because that's what you're calling for.
Yeah, and I think I'm seeing two sort of strands of hope, really. I mean, inclusion health, in other words, the best care of people who might have been prisoners, might be street homeless, might be forced migrants, and so on, is definitely a space where its integrated care partnerships in particular, I think, have an opportunity to do. We're about to publish with Pathways some more work that looks at maybe the 6 or 7 steps that need to be taken, and I know that NHS England have got some work coming that draws on great work that's being done across the country. But just to give a different example, different take on your same point about the opportunity of integrated care, if you take somewhere like the South Yorkshire integrated care system where I'm working now, or one of the ICBs where we're working now, real focus on school readiness as an indicator of exclusion. We know that if you intervene in someone's educational accomplishment at that younger age, it costs about 15 times less than trying to remedy the challenge as you go into your later teenage years. We know too internationally that you can predict difficulties of school readiness using 6 data items in the first 6 months of someone's life. So this is a foreseeable challenge, and if we're thinking about integrated care, bringing education, bringing health services and social care services at the margin together, then surely school readiness is a place to focus. I'm really pleased that colleagues in South Yorkshire, led by the Mayor and others, have prioritised that as our #1 health inequalities focus for the next 5 years. And Michael Marmot talked about the fact that while school readiness rates have improved in this country over the last 15 years, the inequality gap in school readiness rates hasn't changed at all. So we can't do more of the same. We're going to need to do different things and run some experiments on what works.
That is a hopeful comment in terms of true prevention right at the source.
Absolutely. But it shifts too, doesn't it? It raises really difficult questions, because when we think about health inequalities, perhaps in older adults or someone like myself in middle age, often we're talking about someone who is not in contact with services. The homeless conversation we were having. Obviously, for children and young people, there's a universal pathway. There is a pattern of involvement. So, I'm working now with our health visitors and others, but we really need to think about what are the things we could do that would begin to shift the dial. Also raising complex, challenging questions about what the boundaries of the state are in the life of a household. So not easy stuff, but as I say, both morally and economically, absolutely where we need to be as a country.
Absolutely, and perhaps politicians who are listening to the podcast will take some lessons from what you've said. Going to the workforce now, and the publication of the NHS Long-Term Workforce Plan, I'm going to delve into detail around retention and the growth of the workforce. But stepping back, it's a once-in-a-generation, self-proclaimed once-in-a-generation document. As someone with your vast experience across the NHS, how has it been received? Because it's quite a bold document and a brave document in many ways.
Well, it's a challenge to leaders in the NHS, isn't it? It's easy to look at documents produced centrally and say, well, there should be a bit more of this or a bit more of that. But actually, I think what Navina and Amanda and others have delivered is a real opportunity for educational institutions, for NHS providers and others to partner up and try and do something different. Who couldn't be upbeat when there's 2.4 billion in the pot, 74% more training places for health visitors, just to go back to the earlier conversation. So lots of reasons to think, in a sense, some excuses off the table. Now we need to go do, don't we?
Absolutely, and I think that's the challenge or the call to action. The plan itself, if we can go to the retention piece before the growth piece, it's predicated, it says, embedding the right culture. Because we've had, of course, the numbers, 170,000 that left the NHS last year for various reasons, including work-life balance. I want to dig deeper a little bit about how important the right culture is and leadership. But before that, let's talk about a subject I know is close to your heart, which is inclusion within the workforce. We've had the improvement plan now published by the NHS as well in June. What's your take on this? Because the numbers are quite stark. There's a lot of work to be done, some improvement. How important will it be to embed that within the culture of the NHS?
Oh, I think hugely important. People need to look around them and see the role models of what they can and they want to be. I mean, I work for an organisation where we've made great strides in terms of the neurodiversity of our leadership, in terms of the diversity perhaps around sexual orientation in our leadership, but we've got a very long way to go at RDASH in terms of black and minority ethnic leadership spaces and faces. So a real challenge. One, to be fair, at Samwell, I think we made some progress on. I was chief exec there for 7-8 years, and we did see a marked change in the nature of the leadership. And that's obviously not the only element of an inclusive culture, but it is a very important one, and one we need to make a real difference to. I thought there were some interesting voices recently really talking about this being about courage and determination as much as targets and plans, and I'd certainly align myself with that view.
And the plan also is predicated on getting leaver rates back to or above pre-pandemic levels, an improvement by 15%. The other element that I see as the flip side to inclusion is also the support for the well-being of the workforce. The NHS staff survey talked about a third of the workforce reporting potential burnout and stress. Again, if you can sort of focus on that, what are you seeing on the ground? What are your plans? Because without that, we're going to have a struggle in terms of retaining people. So
I think we are, and we need to recognise it's a shifting position, isn't it? What we know about once-in-a-century events or major things like a pandemic is it alters the calculus that we make as individuals or in families for our relationship with with work. So at RDASH we've got a very extensive wellbeing offer, very strong restorative supervision culture, but I think where we've got to make further progress, and where the NHS generally has, is really how we support people to work flexibly. There's an obvious point around retirement patterns, but there's also a point about people as they go through their life. They raise family, they have caring responsibilities. 40% of the people who work in RDASH have carer responsibilities. Are we really, as an NHS, yet geared up to support people who might need a little bit of time here, there, may not always be able to be themselves, their best self at work because of things that are going on outside of work? So we need to get a package that is compassionate in terms of line management around those individuals. Of course, part of the burnout is where you started earlier, which is if I'm working with people who I don't know, who I don't recognise, then my sense of stress and strain is going to be different. One of the paradoxes I said to our board the other week is you often sit in senior roles and you imagine that what the service needs is more change or faster change. And you talk to people, in my 100 days, I've talked to hundreds of people working in our organisation, and what they experience is almost persistent, never-ending zigzagged change. So one of the things I want to focus on as a leader, and I'm sure other colleagues are doing as well almost, is how we nurture and preserve what works well. If 100% of our conversation is about the 10% of things that we need to change, you can't really mistake our staff if they think, goodness me, everything is shifting around me. So there's that real sense of trying to support people. But as I say, perhaps one of the areas where we need to do better, and maybe where the next iteration of the workforce plan could do a little bit more, is really, are we truly comfortable with a flexible workforce? Because sometimes we sound like we're not.
And that's a challenge to leaders. I mean, we've had reviews, Messenger, etc., where actually the role of leaders at any level is going to be crucial in making sure this is executed on the ground.
Well, look, you make reference to my long career, which is a very polite way of saying I'm old, isn't it?
I don't mean that.
And the reality is, when I joined the service in 1994, for most clinical professionals, if you made it through training, you'd work in England. The world is now your oyster, and we can't change that. So in a sense, we're in a global market for healthcare workers. This needs to be a wonderful, rewarding place to work. And the notion that the buildings are half decent and the tech usually works is a hygiene factor, isn't it? You want to be able to live out your dreams and your hopes in the work that you do. And I wonder sometimes whether we're creating a culture in which people feel they've got that element of agency, that element of possibility. If you take RDASH, we've got a remarkable research capability around our grounded research function. That's one of the reasons people come and work with us. And we need to find those 1% that make it rewarding to work in the organisations that we're leading, but really we're borrowing for a period of time.
No,
and trying to nurture,
Absolutely. So moving from retention to growing, the plan, of course, has very ambitious targets, doubling medical places, something you know about in terms of being part of the founding of Aston Medical School. But I want to hone in on the focus on mental health nurses, learning disability nurse specialists, very important to you where you're doing that. There's a focus on growing those numbers, which is to be lauded, of course. But I'm keen on understanding your thoughts about how it envisages or reimagines the way people are trained, because the plan talks about levelling up training opportunities, use of apprenticeships. So there's a great opportunity to perhaps be even more diverse in terms of the attraction.
Hugely enthusiastic in this space. I think probably the two things from the plan that I'd pick out that are almost most exciting is the notion of really leaning into apprenticeships with the NHS, changing the funding model of the NHS around apprenticeships, which will be intensely welcome. But secondly, a much more immersive approach to the curriculum and to training. And I think that's very important. I think that's very important because we have some very traditional notions of what the curriculum should be and of how we create placements. And when I think about something like not only helping Asif and others to found Aston Medical School, but bringing it into the workplace within a hospital setting, we really are going to need to be creative. Otherwise, we're going to take those staff that you've already been talking about in terms of burnout and say, please could you supervise, please could you mentor, actually 2-3 times more than the people you were working with before. So that is a real challenge. I think in terms of apprenticeships, one of the things the NHS can do very well is to reach into our communities and think about people who are often excluded from employment possibilities. In my work at Sandwell, we did an awful lot of work on people who were at risk of homelessness, moving into employment, and we had a large programme supported well over 150 people on a benefits-free basis, both with accommodation and with work. We've done the same with refugees and migrants, done the same with people leaving the care system. So I very much hope that emphasis on apprenticeships isn't simply us, in a sense, working with the local college and trying to churn through numbers. It's also about us reaching into communities and thinking, where can we get that lived experience? Where can we get that allegiance that the plan uses to advocate for apprenticeships? How can we work differently with our communities? That takes us right back to the inequalities conversation and my point about jobs and houses. That really is the opportunity that's in the workforce plan, I think.
No, absolutely, and that is a beautiful vista, but it also requires, as you've hinted, and very briefly we can touch upon, a reimagining of perhaps digital pathways and revolutions in the way we actually train, the medium through which we're training.
Oh, absolutely, and I make no apology for coming back to simulation. I think in terms of people being able to imagine the situations into which they will be working, it's a hugely powerful technology. I myself, with other board members, undertook a simulation just last week on what it would be like to live with or to work with someone experiencing dementia, and to be honest, it was an eye-opener. And I think those simulative technologies are going to be really important to how we bring more people, not just into the workplace, but make them effective in the workplace. Because healthcare is a team sport, and those are technologies enable people not just to learn alone, but to interact with others, which are really the key skills that then make people effective in the workplace, aren't they?
And across boundaries, demographic and geographic as well.
Yes, and look, we're talking sometimes about subspecialist skills here, aren't we? And surely one of the things we mustn't lose after the pandemic is the ability to deploy those subspecialist skills remotely across a country or indeed across continents. That's the reality. We're not going to be able to simply domestically create and locally create all of the workforce and the diversity of subspecialist skills that are imagined in the plan. We're going to have to be creative about that, and that's where I would urge providers to really drive this. I think the lesson is it won't come from educational leadership. Of course, the expertise is there. It won't come really centrally. It's a locally led narrative where now we need to own the opportunity that's been created by the long-term workforce plan. Say, right, how's that going to work round here? What's our slice of that? How can we treat that as a floor and not a ceiling? Let's go further than is envisaged. So 26% more clinical psychologists between now and 36 sounds a lot, doesn't it? But actually, you take over 15 years, that's not the hugest growth. How do we make sure that the money follows these ideas, but then we take people through from training and retain them in the workplace? And that probably means we need to offer a mixed economy of roles where you may work in the private sector as well as in the public sector, where you may have career breaks, sabbaticals. The old lure of saying we're going to hire you and you're going to work for us for 30 years and then there's your pension. I'm not sure in a global context that's the sell it once was. So we do need to reimagine the relationship between ourselves as NHS employers and people who live and hopefully work with us in the local community.
No, absolutely. Thinking about the plan itself and some of its predicates, I wanted to touch upon that finally. And the plan itself is predicated on a number of assumptions, some of which we've touched upon. One is, it by its own phrase, an ambitious productivity assumption. But I wanted to focus on the fact that it's also predicated on the fact that access to social care needs to stay as it is or improve. So there's a huge element here where the impact of social care and its workforce remains if not a lacuna, definitely a vacuum for us to think
about.
Look,
and it is frustrating, isn't it, that NHS leaders, including people like myself, end up sitting in rooms saying, and then social care. Effectively, we've written the back end of a story. The front end is around social care. The document itself has the supposition you describe, and then there's a wonderful paragraph in there, I forget exactly which one, which describes how essentially that assumption is entirely flawed by current experience. And you can see that, look, in my own family life, people receiving domiciliary care from people paid less than the real living wage, who are then paying for a taxi to go between appointments at 10 o'clock at night, and we wonder why we can't retain people into those roles. What we need to be doing is seeing integrated care systems not wait for someone on the steps of Downing Street to talk about social care remedy, but to be biasing our funding into shoring up that workforce. Now, I'll tell you why from an NHS point of view we need to do that. We need to do that because people are going to stay in the workplace in the NHS if they feel like their jobs are doable. Your job doesn't feel so doable if you look over the fence into colleagues in social care, education and so on and think, goodness me, there are big gaps. So there's a self-interest as well as a care interest in us getting this right. And it may well be that some NHS providers need to reach much deeper into this space. I know Jim Mackey's done that work. We work with a number of care homes on a partner basis in RDASH. I'm sure we will see that work grow. So you're right, that is one of the gaps in the document. Steve Black, I think, has described it as a training plan, not a staffing plan, and I think Steve's a very wise man in saying that. It's now for the NHS, I think, to turn this into a staffing plan. I mean, there's one more challenge, though, isn't there, in what's come out? And this does draw on the experience of trying to create a new medical school, as you said, in Birmingham. We really haven't thought about breaking down the silos in the curriculum by which we educate people. So it's fantastic that mental health is the largest single percentage beneficiary of the growth envisaged in the plan. But wouldn't it be equally good to make sure that mental health parity is a core part of the curriculum across so many roles in the health service? Otherwise we end up in a competition of silos. We need to have a look at what we're teaching, at what we're training, and break down some of those barriers. And that means we need a little bit of regulatory relaxation in how we set up curriculum, how we set up new providers. That's where the real challenge now is. If we're going to make progress on this over the next 2 to 4 years, we really need to see a slightly different approach from a number of the bodies whose names are in the annex of the report in terms of how we regulate our curriculum, in terms of how we think flexibly. To be honest, we need to think about it like we do as patients. We don't see those barriers, do we, Sal? So we need to break that down in how we're training our people. Absolutely.
I'd like to end with the look back again at inequalities and the work that you're doing at RDASH. The next few years, I know you're with your colleagues putting together a strategic plan to empower communities to work with citizens and patients. Can you give us a little bit of an insight into what that's looking like? Because, as you say, ultimately there has to be integration, there has to be true parity with mental health and physical health. But it starts in the community, and it starts with co-creation with citizens and patients.
Well, look, you've put it very well, haven't you? Health is a co-created thing, and actually what the NHS has to do and what RDASH has to do isn't so much go out there and create the power, it simply has to recognise the power that is there. And so we'll be working to nurture that, and we'll be doing that in perhaps 2 or 3 particular ways. How we spend our money needs to reflect the neighbourhoods of greatest exclusion that we work with. We need to create a parity of esteem with our colleagues who have lived experience, who are working as peer support workers, who are working in the voluntary sector, relying on them not on a contracted basis or a procured basis, but as genuine partners in teams, as we do with something like our people focus group at the Wellness Centre in Doncaster. And then thirdly, I think, and crucially, in how we make decisions, in what we prioritise within the NHS, we're looking to break down some of those traditional barriers. So the challenge of producing a strategy is that someone will say, well, tell me exactly what we're going to do. Well, if you're going to spend 5 years working with the power that's in your communities, it's not for us to say entirely and wholly what we're going to do. So there's 28 or so commitments that we will give in public between now and Christmas time about where we want to make a particular difference. But really what the strategy at RDASH is about, like other organisations in North East Lincolnshire and West Yorkshire, is really listening to and working with communities on a long-term basis. And we know from Preston, we know from other places that makes a genuine difference to mental health outcomes and to health outcomes in what we would traditionally think of as physical health. So that's where we're going to put our emphasis. Different kind of organisation, different kind of focus, hopefully one that we can learn from others like Merseycare as we go along, because it's this journey's been talked about before. Really important that the authenticity of going on that journey and learning from it is what our communities hear.
On that hopeful note, Toby Lewis, thank you for your candour and your vision. It's been a pleasure.
Thank you.
If you've enjoyed this episode of Voices of Care, please like, follow or subscribe wherever you receive your podcasts. And if you want to find out more about how we're enabling the healthcare workforce of the future, please visit newcrosshealthcare.com/Voices of Care. In the meantime, I'm Suhail Mirza. Thank you very much and look forward to seeing you on the next episode.